Kamasaka. I'm co-chair of the Global Digital Health Network, and I really welcome you to this webinar. Today we are going to be hearing from our colleagues from USAID, headed by Adele, the Senior Digital Health Advisor to USAID, and she will be introducing our speakers for the day, plus moderating the session. Thank you so much once again for joining. Adele, over to you.
Excellent. Thanks so much. And Carol, before I take it away, do you want to say a few words about the Global Digital Health Forum? I know I'm really excited about the fact that it's moving to Nairobi this year, and I know there was just an announcement that went out. Do you want to speak to that as well?
Thanks, Adele. I thought I would summarize at the end, but it's okay. I can speak through it. Excitedly, this year, the Global Digital Health Forum is coming to Africa. It's going to be in Nairobi, Kenya, from the 3rd to the 5th of 4th to the 6th of December this year. And we are also happy to mention that the call for abstracts has been open, and it will be open until June 10th. So kindly submit those abstracts. We are really excited and looking forward to hearing from all of you about the amazing things that you've been doing. Over to you, Adele.
Excellent. Thank you so much, Carol. And welcome, everyone. My name is Adele Wagaman. I'm a Senior Digital Health Advisor at USAID and the Bureau for Global Health's Center for Innovation and Impact. And it's a pleasure to be with you for this conversation, sharing insights from the use of data and digital technologies during USAID's global COVID-19 vaccines delivery effort. I'll help set the scene by providing some context for this research and our key findings, and then open the floor for a round-robin series of questions and brief answers from the panelists. Before we get started, I want to thank the organizers of this event, Global Digital Health Network co-chairs Rose Nzioka and Carolyn Kamasaka, who we just heard from, as well as Kristen Weymouth and the team at Tech Change producing this event. And let's see if I can get my slides. There we go. I also want to thank the speakers with me today who are joining us to speak to their research. I'm excited to welcome, and maybe if you could just wave so folks know who you are as I call your name. From Data.FI Honduras, Diana Gonzalez. From CHISU Indonesia, Noni Parmawati. From M-RITE DRC, Constant Kingogo. And from Digital Square Kenya, Dominique Mutai. So what I'll do, speakers, is when I hand it over to you for the questions, I'll invite you to introduce yourselves in a little bit more detail as you share information about your research. Finally, I want to acknowledge and extend appreciation to the broader team of individuals at CHISU, Data.FI, Digital Square at PATH, M-RITE, and USAID, who worked together over a period of about 18 months to conceptualize the research and bring it to fruition. And here you can see a picture of some of us who gathered in Washington, D.C. in late 2022 for a workshop to develop the theory of change accompanying the research that I'll talk a little bit more about in just a minute. So we already know data and information are critical to respond to a disease outbreak. And we also know that when investments in digital technologies and data systems are siloed, we see common problems. And this is the case in the context of routine service delivery, but especially in the context of fast-moving disease outbreaks. We see lack of ability to exchange data between systems, a lack of interoperability. We see duplicative data across systems or gaps in critical data collected, a problem we refer to as fragmentation. And we see systems that fail to scale, especially beyond the immediate funding cycle. And that, of course, is a problem for the people who are using the system and depending on it to deliver health information and services. We know digital tools can facilitate timely access to data, yet without strategic planning and coordination, the broader systems strengthening impact of these tools can be limited, despite millions of dollars of investments. So folks probably recognize this slide. This is a slide from from a whiteboard in Monrovia, Liberia during the Ebola outbreak in West Africa around 2014, 2015. And USAID started with a research agenda during that crisis to look at how data and information were being used and to assess what we could learn. And some of the findings, there were a number, but some of the findings were to understand and build country digital health capacity for digital systems management and use, to increase the use of standards to enable interoperability, and to invest in the workforce and in institutions to support them in their digital transformation change management journeys. USAID incorporated a number of these insights into USAID policy in the form of the Digital Health Vision, which launched in 2020. And we began in a dedicated way working with our implementing partner and government partners to really look at how we could move those principles from policy to practice, how we could begin to modify the way we approach our investments, the way that we work with our partners to take those core principles from the digital health vision and bring them to life. But of course, it's not like a light switch that you can flip on and off. Digital transformation is a complex journey that takes time. And what we saw is that while there was a lot of progress, and we'll hear about this in a minute from some of the speakers, in terms of how digital systems were invested in the context of the COVID-19 response, we saw that there were a lot of the same challenges that we had seen during the West Africa outbreak of Ebola. We saw that there was fragmentation of digital systems that made it difficult to assess what was happening, especially in the context of a fast-moving disease outbreak. And then you have a quote here from Jean-Thierry Colombo, who at the Global Digital Health Forum this past December was in Washington, and he talked about this continuing problem and how it's a really big headache for governments to understand what's happening when you have systems that don't share information. So this is clearly a critical problem. So the global vax effort was part of USAID's COVID-19 vaccines delivery response that began in December of 2021. And it allocated about $1.8 billion in funding to over 120 partner countries, including to support the donation of 688 million vaccine doses for COVID-19. And across the COVID-19 emergency response, from the early days before we had the vaccines up until the vaccine's introduction and then delivery, we saw digital systems being used in a range of different ways. And some of those use cases are captured in the document you see on the right, the Primer on Digital Solutions for COVID-19 Vaccines Delivery. If you haven't taken a look, I encourage you to do so. And then on the left, you see the range of kinds of digital systems that were being used, everything from planning to help identify high-risk populations for vaccination, to vaccine certificates, and then monitoring systems to ensure that we were tracking how it was going with the vaccines administered. And what we wanted to do with this special supplement was to, with this cohort of implementing partners, take a closer look at understanding the relationship between the way digital technologies and data systems and data were being used as part of the COVID-19 response in the countries where USAID was working, and to look more closely at the interrelationship between these investments and the country digital health enabling environment. And some of the specific questions we were interested in is, can these digital health investments that are very clearly focused on meeting an emergency need in a crisis context be designed and delivered in a way that meets those emergency needs, which is the first priority, but also contributes post-crisis to ongoing health system strengthening? And if that's possible, what are the factors that support that pathway, or what are the factors that inhibit that pathway? And finally, how can investments contribute to global health security by bolstering country health emergency preparedness and response capabilities? So trying to create a virtuous cycle between investments in digital and data systems that are made in the context of a crisis, but can meet those immediate needs, but also have enduring value beyond the crisis period. So I won't walk through this in too much detail, but this is the theory of change I alluded to earlier, where we tried to bring together a number of activities from across implementing partners. And implementing partners were working on very different things. Some were just working on data and data use. Others were working primarily on digital systems adaptation and management. And how could we look at the benefit that those approaches were taking we're bringing in the context of the emergency response. So that's the orange box, the immediate outcomes of activities at the country level. And then what could we see within the limited period of the research about what the impact of those immediate outcomes were on the COVID-19 response. So what could we say about how vaccines were delivered? But then also, what could we perhaps begin to see about longer-term health system strengthening, such as via activities that strengthen the e-health or digital health building blocks around country leadership and governance for digital health, or standards and interoperability, services and applications. And so I'm excited to have the research team or representatives from the research team here to share with us some of what that looked like from their perspective. And I'll also note there are, I think, probably a number of people who are in the audience of this webinar who participated in this research in some way. So thank you to all of you. I'm glad that you're here. If you would like to add comments at any time, please feel free to use the chat function. That goes for the participants in the research team, but also for all of you. And the chat function is also how we'll be collecting questions. You can go ahead and start to enter your questions as they occur to you, and I'll do my best to track them. And when we get to the discussion period, pull from them to help guide that discussion period. So just to quickly give you a couple of examples, interventions that some of the implementing partners represented on this call took forward were everything from developing guidance materials around data entry to developing data analysis and visualization. So a lot of data interventions. Examples of the immediate outcomes include, for the guidance materials, those being developed and put into use. Strengthening data entry skills as another example from data collection. And then around data use, strengthening data use and coordination, and increased coordination of COVID-19 response in line with national COVID-19 plans. So bringing data from different actors together to support meaningful data use. And this is a closer look at the intermediate outcomes of activities at the country level, together with what we were looking at as potentially contributing to longer term outcomes and impacts at the country level. And for folks who are interested in more detail, I warmly welcome you to review the special supplement of the Oxford Open Digital Health Journal, where this has been published, where in a commentary we summarize this, but you can also find quite a bit more detail there. So I'm going to just very quickly go through the insights, some of the insights from this research, and then I'll open the floor for the panelists. But at a high level, what we did see is that digital health investments designed to support COVID-19 vaccinations could add value beyond the emergency phase of the response. We also saw very clearly that prior investments in a country's digital health enabling environment helped emergency investments contribute to an effective pandemic response and support other health areas, including beyond the COVID-19 response. And then we also saw a number of stopgap efforts, new data systems that were created specifically for COVID-19. And in some cases, that was the only path forward. But we did see that those generally tended to have challenges later on in the response and tended to be disconnected from the health system. So with that, I'm going to now open the floor to the panelists and ask everyone to please introduce yourself as you take the floor. And the first question will be around summarizing the case study that your organization contributed to the research. And I will start with who I see first. So Diana, I'm going to hand the floor to you. Thank you so much.
Thank you so much, Adele. Well, my name is Diana Gonzalez. I'm a technical advisor of the Data.FI team. And thank you again for allowing us the opportunity to share research with today's audience. So our study takes place in Honduras, in the two largest urban areas of the country, Tegucigalpa and San Pedro Sula, which coincide also with the largest health regions in the country. Our intervention consisted in implementing a new data use methodology in COVID-19 situation rooms. And our study specifically tried to elucidate the effects on decision-making and program implementation during the pandemic. So situation rooms, also known in some countries as epidemic control rooms, are data review meetings organized to make sensitive and critical decisions. This was not a new concept in Honduras. It was pretty popular in the region. But the new intervention was a data use strategy, which was proposed and introduced by USAID with USAID. COVID-19 vaccine. So the government was facing tough decisions at the moment, like how to use the limited resources, how to de-escalate, for example, triage centers and expanding vaccination strategies at the same time. So coordination between the different government levels and units was key, but it was not happening as smoothly and rapidly as necessary. So in the heart of the data use strategy, there's the prioritization of indicators through a logic model, and also 5 key elements of this intervention, which include multidisciplinary problem solving, concise scheduling with meetings no longer than an hour, focus on data visualization, quality improvement methods, and action planning for accountability. So also part of our intervention was a blended capacity strengthening approach, which included workshops, but also like side-by-side capacity strengthening and other activities that foster governance and leadership. For the study, we used self-assessment questionnaire and semi-structured interviews to try in situation room participants, also health authorities and our project staff, to try to understand their perceptions around their mastery, proficiency, and confidence of the data use, knowledge and skills that were transmitted through the intervention, and how if this had any impact on an improved digital health environment. So I won't get into too much detail, but we found 5 main themes, which include data analysis and visualization, peer collaboration, replicability, leadership, and governance. The first 3 are related to the workforce, WHO e-health building block, and the later leadership and governance related also to the leadership and governance e-health building block. So with that, I can pass it to my other colleagues to summarize our case study. Thank you.
Thank you, Diana. Noni, I will pass it to you and let me know if you prefer to use slides or not.
Yes, thanks, Adele. Yeah, if you can help me to share slides, that will be very useful. Okay, so good morning, good evening, everyone. I'm happy here to be with you to share the result from our collaborative learning activity. So my name is Noni Parmawati. I'm from CHISU Indonesia as Senior Monitoring Evaluation Manager based in Jakarta. So the study title from our CLA activity is, does investment in COVID-19 information system strengthen national digital health architecture? This is a lesson learned from the Burkina Faso, Indonesia, Mali, and Suriname. The study setting, the sample included the 4 countries, Burkina Faso, Indonesia, Mali, and Suriname, where CHISU received COVID-19 funding to provide support related to digital health architecture. The research team used purposive sampling to identify specific individuals from the relevant government units, donors, and implementing partners to participate in the key in-depth interviews and also the FGDs. The learning questions from this study is to identify or to understand what extent and how have USAID COVID health systems, data, and digital health investments advanced the country's digital health architecture by lowering the financial and management burden of the completing digital systems and by improving interoperability between national digital health systems. And then from this learning question, we broke this question into 4 research questions. For the first research question related with how did investment in national COVID-19 vaccination data system can change the overall interoperability of national digital health systems, we learned from the study about a number of interoperability related efforts with a primary purpose of enabling COVID-19 data exchange. So across all the study countries, the participants felt advanced national digital health architecture development. Many of these efforts were initiated in response to the COVID-19 pandemic, including activities with USAID COVID investment or those without the COVID-19 funds. With this non-COVID-19 USAID funding, especially for the Indonesia case, Indonesia developed the interoperability platform, we call it Satu Sehat, and other necessary components. This is including a terminology service, health worker registry, master facility index, and interoperability data standards that all enable national data exchange across many health programs, demonstrating progress towards a national digital health architecture that includes but goes beyond COVID-19. So for the second research question, how did the level of integration of COVID-19 vaccination data flow change over time? From this study, we learned that demand for real-time data, COVID-19 vaccination data initially resulted in the proliferation of parallel data systems across all study countries, according to the study participants. This proliferation increased the burden of healthcare workers and data analysis to deliver real-time data to decision makers for reusing. And additionally, actually, the lack of adequate infrastructure supporting COVID-19 vaccination data system, as well as human resource capacity to accurately develop and use data system presented challenges to the streamlining and optimizing the data system that were developed or used. And then for the third research question related with the National Digital Health Architecture lesson, were learned from the implementing COVID-19 vaccination data system. From the study, the finding was very interesting because initially gathered through this review and validated with the key in-depth interview and also the FGD, we confirmed that no formal enterprise architecture, actually, documentation existed in any of the study countries at the time of data collection. And rather than directly contributing to the formal documentation activities, the COVID-19 vaccine digital investment we discussed with the study participant were used to conduct a variety of activities that are initial steps toward informing future decision-making related to the digital health architecture in our study countries. And for the last research questions related with the to what extent were COVID-19 vaccination data used in decision-making for the COVID-19 response, the result variation result from the 4 countries. Take an example from Indonesia, the participant primarily spoke about how the data available in the various COVID-19 data systems and applications were used to optimize the COVID-19 vaccination efforts. But the other countries like Burkina Faso and Mali, they raised concern related with the data quality and also a lack of sustained internet connectivity that contribute to the data quality. And in Suriname, they highlight about the timeliness and the completeness of the data collected through the for the COVID-19 vaccination. So for this study, as a conclusion, although the USAID COVID-19 vaccine digital investment in the 4 countries did not contribute to the development of formal national digital health architecture documentation, means using the USAID COVID funds, but some progress was made in strengthening the overall national digital health architecture. The donors and the government stakeholders should examine whether their digital investment originally directed to a health emergency can also improve routine HIS and build resilience in health system against the future pandemics. Yeah, I think that's all. I believe with me, I'm the representative of the research team. Here in the webinar, I believe there's also another team from this research. Thank you.
Excellent.
Back to Adele.
Thank you. 2 really excellent synopses. Thank you so much. Very different in terms of the focus on data and then the focus on contributions to architecture, but a nice way to represent the various activities that were included in the continuum included in this research. So Constant, if it's okay, I'm going to hand it over to you to talk about the work that you and the M-RITE team did as part of this research agenda. Thank you.
Thank you. Hi, everyone. Sorry for the video because I am in the field. The connection is not good.
No problem.
Okay. The case study is intervention and adaptation to strengthen data quality and use for COVID-19 vaccination, a mixed method evaluation in 3 countries, Vietnam, DRC, and Niger. Yeah. The many countries, including DRC, Vietnam, and Niger, has used digital health solution to support vaccination against COVID-19, but implementation was not easy, leading to adaptations. The main aim of study was to find out more about when there's adaptation during implementation were able to improve the ability, quality, and use of COVID-19 immunization data. But also to see do what stands this adaptation have staying in the existing digital health system. Okay.
Excellent. Thank you, Constant. And I think it's helpful to recall, I didn't mention it in my framing remarks, that there were multiple aspects of the response that were challenging, including the fact that we were trying to track a multi-dose vaccine course across all age groups. And many of the digital systems that were in use to track immunization were not set up to enable that kind of immunization pathway across all age groups. And so in addition to the other complications around the COVID-19 pandemic and the response it required, there was a lot of complexity around tracking immunization doses for COVID-19 vaccines as well. And so now, Maurice, if it's okay, I'm going to hand it over to you to talk about the work that you and the Digital Square team led. Thank you. Sorry. I apologize. It's still early for me and I'm short on coffee. Dominic, I am intending to pass the mic to you. I don't know where Maurice came from. Over to you.
It's okay. It's okay. I was surprised. Okay. Yeah, thank you. So I'm Dominic Mutai, Digital Squared Path, based in Nairobi, Kenya. Yeah, so I'll describe the work that Digital Square did in terms of COVID-19 data backlog root cause analysis. So we did a study in 4 countries, but I'll describe mostly our experiences in Kenya. So for Kenya, the work that we did a mixed method study just to find out what are the reasons causing data backlogs. And data backlogs are actually records of vaccinations that have not been entered into the electronic system. So in Kenya, we, like other countries, we deployed a digital health solution. It was called Chanjo Kenya. Chanjo means vaccine in Kiswahili. And it was purely point of care and real-time data entry with no backup for paper-based systems. And yeah, so through the funding from USAID, we wanted to understand really, is there a backlog, first of all, and what was causing that data backlog of unentered records. For Kenya, we did this in 6 counties in Kenya, a number of sites, 50 sites, a mix of urban and peri-urban sites, 42% being urban, 52% being rural. And we were interviewing healthcare workers, basically the ones dealing with vaccination, the vaccinating nurses, as well as data clerks, finding out the experiences and the reasons why they have data that has not been entered into the electronic system. And from this, both qualitative and quantitative data collection, using observations to observe really how the processes are flowing. And we found out that, yes, there were data backlogs, and the reasons for those data backlogs were actually described in 4 thematic areas. The first one being technology specific. This included issues with the equipment that are being used, the tablets, and even the system itself. There was also issues of infrastructure, and this was actually the biggest hindrance or causes of the data backlog, because more than 94% reported having issues with the infrastructure, and this was because of what are called data bundles, internet connectivity, which was not available to the healthcare workers. We also had processes as one of the reasons for the data backlog. And processes include data entry being done in different locations from where the data vaccination was done, specifically for large vaccination campaigns in market centers, outreaches in schools, and all that. where they quickly do mass vaccination, and then they go back and enter the following day or days later when they get back to the facility. And also specifically, issues of system changes not being able. And lastly, the other reason for data backlog is people. When we talk about people, we found that really there was, first of all, there's insufficient healthcare worker capacity, and even the number of healthcare workers. And then also, really, whose task was it? The nurses would say it's a task for the data clerk to do the data entry. The nurses say, I'm not supposed to do the data entry. So technology, infrastructure, processes, and people, and were described as the reasons for those data backlogs. Thank you.
Thanks. And it's interesting, there was a lot that was unique and different considering the West Africa Ebola outbreak and the COVID-19 pandemic, but there were also a lot of similarities, and this challenge of limitations in infrastructure is one very clear parallel where we saw those limitations directly impacting the ability to collect and report case data as well as immunization data on a timely basis. And that clearly to me is one of the things that shines in the research as an area where the global health, but also the broader global development and technology communities need to do more to think about how we can continue to expand connectivity access. In fact, with the Ebola research, there was a mapping done that compared where there were niches where zoonotic outbreaks were more likely to take place, overlaid with where there were gaps in cell phone connectivity. And perhaps unsurprisingly, these rural areas tended to be more of the hotspots where these zoonotic disease transmissions were likely to take place, and yet were the parts of these countries that were the least well digitally connected. And so it was a real compelling reason to think about how we can continue to extend the access and reach to digital connectivity infrastructure. So Deanna, I'm going to hand it back to you again and move on to the second question, which is one that I'm curious to hear the answers to, and that is to describe the biggest takeaway that either you individually walked away from the research with, or something that you see your organization taking away from the research. So Deanna, over to you.
So I think our biggest takeaway as a research team was that our person-centered approach was successful in promoting a data use culture and achieving replicability and sustainability of the data use strategy. So we were able to confirm one of our hypotheses that workforce capacity strengthening in data use is essential for driving the use of evidence-based data for decision-making and also to promoting this digital health environment. So we saw that after the intervention, and this is reflected in our data, that MOH placed more value and also demanded more high-quality data. They really saw the difference in data quality as a key element for their daily activities and decisions. So we believe that this in the future will enable future health investments in the country in terms of development of systems, interoperability, tools, and for example, the use of dashboards. As you were describing the Ebola epidemic, I remember we also, through a different study, understand how complicated is the infrastructure in Honduras and the connectivity. So we believe that by promoting more data use, this will also lead to other investments for the whole environment. So we know that workforce development in Honduras and probably in other countries is also challenging. It's not an easy area to work in. There's huge staff turnover, and also this is subject to political changes and turmoil in occasions. We saw both things happening during our implementation and our research. So this is definitely something that threatens sustainability. But I think our approach, which was a mix, like a blended capacity strengthening approach, mixing the side-by-side training with other types of reskilling and upskilling, ended up in a successful increase in ownership and promoting the replicability of this methodology. We saw that staff at first were a little bit threatened by the intervention, especially about the accountability element of the methodology. But at the end, they saw a lot of value in the intervention. They mentioned how important it was for them to have authorities participating in this meeting, not only like technical staff, and also the soft skills development. We usually tend to focus more on the technical skills, but this intervention also develops soft skills, which are really important to facilitate peer collaboration and decision-making. So they really value that component. And even some of them quoted that how before this intervention, they were not able to speak in public, or they didn't feel compelled to lead a meeting like this. And after the intervention, they feel prepared, which we take as a huge improvement. So finally, in terms of replicability, it was also very promising to see that a third of respondents reported to feel confident in replicating this approach for other health threats or pandemics. And we're also pleased to share with you that even after this study, this approach has been replicated for other diseases, including dengue, chikungunya, monkeypox. So this is really, we're really excited about how this has been sustainable, and it has continued with some support from USAID, but minimal compared to what we did at the beginning of the pandemic. So I'll leave it there. Thank you.
Okay, thanks. Yeah, that's a really beautiful example of the close partnership with the government and designing and delivering based on where the government was and what their specific needs were in a way to make the product sustainable and replicable. Thank you for sharing that. So Noni, I'll pass it now over to you. Would love to hear about one of your biggest takeaways from the research. Thanks.
Yeah, I think follow on the 4 research question that we have, I would like to highlight 4 themes here according that 4 research question. So the first is about the interoperability activities to enable COVID-19 data exchange. This advanced planning efforts for national digital health architecture. So this is not only limited to the COVID-19 emergency response activities only, but this is only also how this can affect the planning to very important how to increase the demand, especially on the data use, especially on the real-time data. I think that's very important. That will lead to the how the country been able to develop an interoperability system to support the real-time, not only COVID data, but real-time health data. And the third theme is about, even though no formal enterprise architecture documentation exists, but we see in all 4 countries, all the 4 countries have big efforts, some efforts to advance the interoperability and also to make the health information system can be integrated and also interoperable. So not about the documentation, but how the system can work and can talk each other. I think that's what the country see that's more important during the pandemic, like for example. And the 4th theme is about the persistent data quality concern did not prevent data use in the COVID-19 response, but directed stakeholders to choose certain data sources for their decision making. So this issue about data quality in for the decision making is also very important. How we can highlight all the activities to support the data quality in order to support the decision maker related with the regulation, with the all the decision making at the national and the subnational level. I think that's the 4 themes follow the 4 research question. Thank you.
Thanks. Really valuable to think about, including because we know more vaccines are likely going to be coming through the pipeline, such as the recently approved malaria vaccine. So making sure that we're capturing what worked and helping to sustain it and integrate it into broader interoperability and enterprise architecture over time is useful. Okay, so Constant, I will hand it now over to you. for reflection on one of your biggest takeaways from the research.
Yeah, I can give three big takeaway. First, the results show that decision to adapt original interventions were dictated by need and availability of funding. And second, another big takeaway from this study was that DRC and Niger has a very ambitious plan at first, collecting individual level data on vaccination, but that it was not right for the existing system and resources. So plans were made to shift to aggregate data collection, and adapted intervention lead to improve availability, quality, and use of COVID-19 vaccination data. I can give an example. In DRC, for example, DHS2 tracker was used, and then an Excel file, and then finally DS2 aggregate, and about this DHS2 aggregate has improved data availability compared to DHS2 tracker. And consideration of existing system and resources result in intervention that were more aligned with the existing digital health ecosystem.
Thank you. Yeah, I appreciate that emphasis on what is practical in a country, given where the country is with its digital transformation journey and overall digital health. And so that's an important takeaway that I hear in those reflections. Okay, Dominic, over to you for your reflections. Thank you.
Yeah, thank you. So reflecting back, yeah, we realized that the system is ready for digital health disruption. Healthcare workers are ready, and this proved that with the right technology, with the right infrastructure, digital health disruption is possible. One of the key takeaways that we realized is that yeah, old habits die hard. We realized healthcare workers also really had to default back to developing their own registries, paper-based registries, because they felt that really I really still need a backup for what I've entered, just to know that I can fall back to. So change management is very critical if we're going to really digitize and move purely to electronic health records and move the entire system to digital systems. And then we realized that it's possible. We found out that in the absence of other equipment, healthcare workers can default to using their own devices. So using your own device is possible. So we need to come up with policies and guidelines that really manage how to can use your own device. I mean, the penetration of smartphones right now is quite huge. We saw healthcare workers defaulting back to using their smartphones when the tablets that were provided for were not working, were not functional, and using. Yeah, so yeah, the digital health system is ready for disruption, and the healthcare workers are saying, if I can do this also for the routine immunization, I'll be very happy. So that's a key takeaway for us. Thank you.
Thanks. No, that's great. I'm always appreciative when I hear people talking about the change management that's required with the introduction of digital systems. It isn't just a matter of changing the format from paper to digital. It requires new policies and new processes, and it adapts workflows. And I think historically, the global health funding community has undervalued the importance of the enabling environment to support the effective use of digital technologies, but also failed to appropriately recognize the complexity involved in that change management process and the support needed to move countries and to move the teams working together with countries through that journey. Okay, so I want to welcome people to leave questions in the meeting chat. I see Merrick talking about BYOD for bring your own device. And that's great. I hadn't heard that expression before, but certainly back to this theme of what's practical, it makes sense to design things based on the capabilities and the resources that folks have in their hands. And while people are thinking about questions, I see we've got one. I'm going to invite a lightning round of questions from the panelists, asking if there is anything that you personally or that your organization is going to do differently as a result, or if there's one thing you would like to see USAID and global health funders do differently as a result. And I'll give you guys 2 to 3 minutes, maybe 2 minutes each to reply. It can be just a short idea, and then we'll turn it over to questions in a discussion period. So Deanna, I will start with you.
Thanks. So I think in an ideal world, we would have had better timing for this intervention. I think if this was implemented earlier on, maybe not at the emergency phase of the pandemic, but a little bit earlier, we could have promoted a more coordinated and systematic approach with government authorities and other actors in the global health space. For example, we could have promoted a better synchronization with implementation of other digital health interventions. In Honduras, there were pilots for digital tools, also for digitalization of paper-based records or vaccination systems, and we could have paired this intervention and probably achieve a larger outcome. So I think that's something to consider, and I think both experiences are helpful. And in terms of the capacity strengthening, which I mentioned as the biggest takeaway, I think there's still opportunities to improve. For example, through the institutionalization of the training, like creating TOT programs and engaging even more the local partners and local staff to be able to continue this and fight the high MOH turnover. Also, the last thing is, in our research, we found that quality improvement methods was the part that had lower scores. So I feel if we had to redo this again, we would place much more focus on that element because it's the newest element, and also it promotes greater accountability, which is, I think, like the motor behind the intervention. So I'll leave it there. Thanks.
No, that's great. I love this point about don't wait for a crisis to invest in and support this important work. Noni, over to you for your perspective.
Yes, thanks, Adele. Yeah, as I mentioned previously, that we see in all 4 countries, they have a huge efforts on how try to interoperable and integrated health systems, but there's no documented enterprise architecture. I think that's very interesting because if anything personally will do differently, I think we need to understanding about the enterprise architecture. This is not limited to the definition or the common understanding, but I think we need to also understand what is the usefulness of the enterprise architecture. So we all understand why enterprise architecture is needed, even though we see that there's huge efforts from the countries to do everything, but why the enterprise architecture is still required? What is needed from that enterprise architecture? Because this will involve so many stakeholders, because this is an enterprise, and maybe this also involve different systems. And the 4 countries actually now they have the precursor for the enterprise architecture. With the COVID-19 funding and emergency situation, the countries didn't think about the enterprise architecture documentation, but how to respond to the emergency. I think that's the first place that the country think about for the intervention. But I think it can be useful to invest, maybe using the routine funding, or maybe the broader for the broader health sector. This is not for the emergency, but maybe like for more broader and routine health sector. I think that will be useful to focus on this development of the enterprise architecture. And the second thing, what we can suggest to donor in the future, maybe we can strongly advocate to the donor in the future or in the government investments, in the health information system, strengthening and demonstrating the value in pairing investment in the system development and enhancements with the investment in governance and infrastructure support also. Such as an approach that can help to make sure the country data management processes align with data use, for example, for decision making in routine health and emergency responses. And in the future, if we need to develop a new software or application, we need to be ensure that this will not duplication and also ensure the solution. The system have to be fit for purpose, yeah. Even though this is emergency reaction, but I think this is very important not to be duplicated, and this is important to be integrated and interoperable between one system to the another.
Okay, thank you. I love the point about the usefulness of enterprise architecture, and it made me think about the importance of getting granular around the use cases. What are the specific use cases that we're trying to support with this, and how does the enterprise architecture enable that? So I do want to call out a question in chat, and what I'll do, Diana and Noni, is ask you if you have any thoughts, and if you do, invite you to reply in the chat. But Amaranth from USAID is saying, thank you for the presentations and congratulations on your research. Did any of the research hint toward impacts on health outcomes at the patient or community level? So Diana and Noni, if you have any thoughts on that, feel free to reply. And then maybe what I'll do, Constant and Dominic, for you two, is just invite you, if you have thoughts in response to that question, weave it in. And then I'll ask you each to stick to a maximum of 2 to 3 minutes in your reply, so that we have a little bit of time at the end to hand it back to the organizers to help bring us to a close. So Constant, over to you.
Thank you, Adele. I will say the digital investment can play an important role in responding to the health emergencies, but it is necessary that country digital health enabling environment need to be strengthened for the next emergency. For example, all new intervention should take existing system into account. Also, is necessary focus on user-centric design. Digital health intervention should be designed keeping in mind the user's need and capability, this including making them accessible for people with different ability. This is very important. Yeah.
Excellent. Thank you so much. And then Dominic, over to you.
Yeah, I think for us, what Digital Squared Path are thinking differently based on these experiences, that really public-private partnership is very important, specifically with the telcos. Yeah, the biggest issue that we had here was connectivity, and that. So what we are working with the telcos in terms of whitelisting some of these URLs for the Ministry of Health, so that healthcare workers can be able to enter data without buying those data bundles of internet connectivity. So bringing them on board, and I think that's what USAID is really thinking about in the next digital health activity, bringing in the private health partnership. Thank you.
Excellent. More key themes that we heard loud and clear also during the Ebola in West Africa outbreak research that we did around the need for partnerships with telcos. It's great to hear that you're doing that work, really important. And Constant, I appreciated your appeal for people to please use wherever possible existing systems. And we did not measure this in our research, but I feel anecdotally like I saw a lot more use of existing systems in the COVID-19 outbreak response relative to the West Africa Ebola outbreak response of almost a decade earlier. And to me, that feels like important progress. And I'm so grateful to each of the speakers for representing your organizations in the research process and joining us here to share some of these key findings now that finally at the end of that approximate 18-month journey, we have the final product, which I've linked to in chat. It's the Oxford Open Digital Health Journal, which is a relatively new publication of Oxford University Press. And we have an entire supplement that captures this research, describes the theory of change, has a number of different case studies, and a commentary from USAID describing why we undertook this research and some of the key takeaways that we're walking away from this with. So a big thanks to the speakers, a big thanks to all of you for joining, to the research teams. I see a number of familiar names in the audience. So for everyone who contributed in some way to this research, many sincere thanks. It's wonderful to have this opportunity to be able to share out. And I look forward to continuing this conversation because these findings and the work that you did, as we see in the research, are living on. And it's important that we sustain this conversation about how we work together through partnership, including, as Dominic was saying, with the private sector, to take these lessons and insights and drive them back into practice so that we're adapting as we learn. So with that, I will hand it back over to the Global Digital Health Network co-chairs to help wrap us up and share any other final announcements they want to make. So Carol, back over to you, and thank you.
Thanks, Adele and your team. Those were really insightful findings, and we really look forward to more conversations and more collaborations that will come after this. Thank you so much to the speakers and to our audience for participating actively. We do look forward to more engagements in the future on the upcoming webinars, but also we look forward to your upcoming sub-abstract. The call for abstracts is out once again, and it is closing on the 10th of June. Make sure you get those abstracts in. We'll be excited to see them. We'll be excited to hear from all of you. Thank you so much, Adele and your team once again, and everyone for attending today's webinar, and wishing you a very good rest of the day. Thank you and bye.
Thanks so much.